Welcome to today's Q&A, and today we are joined by Dr. Sanchez from UR Vistahermosa, and we're going to talk about miscarriage and repeated miscarriage. Welcome, Dr. Sanchez.
Welcome. Hello.
Thank you so much for taking the time to talk to us about such an important topic that so many patients, they ask us about miscarriage and recurrent miscarriage all the time. They feel guilty. They wonder if there's anything that they could do to prevent it. So maybe we can start from the beginning and talk about what is miscarriage and what is a recurrent miscarriage.
Okay. According to the World Health Organization, a miscarriage is defined, or we define a miscarriage as the spontaneous termination of a pregnancy before the fetus is viable. That means when it weighs less than 500 kilograms, or before the 22 weeks of gestation. But when we speak of recurrent miscarriages or recurrent pregnancy loss, it means that 3 or more consecutive miscarriages or gestational losses have occurred before the 20th pregnancy week. We can speak of primary miscarriages when the woman of the couple doesn't have any child, or secondary recurrent miscarriages when the woman or couple has already had a previous child. Although the definition speaks of 3 consecutive miscarriages, we think that with 3 miscarriages in the whole life or fertility life of a woman, we must suspect that something is happening. Obviously, only spontaneous miscarriages are counted for the diagnosis of recurrent pregnancy. We don't have to count the voluntary or induced abortions.
Mm-hmm.
The American College of Obstetricians and Gynecologists already considers to study the cause of recurrent miscarriage when there are 2 miscarriages. So we recommend to begin the study after 2 abortions.
And it's quite common, isn't it? I was reading that around 1 in 4 women experience a miscarriage. So it's quite common, even people don't talk about it a lot.
Yes, with only 1 miscarriage, we don't suggest or we don't recommend to begin any study, but because most of the times we find anything.
Mm-hmm.
And we suggest or we recommend to wait for another one. But I think, in my opinion, it's cruel to say, if we are purist with the definition, we have to wait till 3. But for me, I think it's cruel to say, well, you have to wait to another miscarriage to begin to know what is happening.
And what causes miscarriage? Because women ask it all the time.
Well, the causes of miscarriage are very, very wide, but if we speak of recurrent miscarriages, when we have to begin with the studies, we have to think about 3 and 5% of the couples will suffer from recurrent miscarriages.
Mm-hmm.
This percentage will vary depending on the age, especially of the woman. A woman under 30 years old has more or less a 25% chance to have another miscarriage. But a woman over 40 years old have between 50 to 60% of having another or recurrent miscarriages. Sometimes it's very difficult to know what is happening. After all the tests, we don't find anything, but other times we find something and we have to solve this problem. If we think about the causes, well, first of all, the most important causes are the genetic causes. Yeah. These are almost responsible for at least half of the miscarriages. But if we think about recurrent miscarriages, the genetic cause only is between 3 and 8% of all.
Wow.
And as I said before, the most important factor is the maternal age. On the other hand, it has happened that one or both parents are carrying an abnormality in their chromosomes. that can produce embryos with alterations in the genetic. So we must do some tests to detect this. Another causes are the immunological causes, and we have to distinguish autoimmune causes. The most frequent are the thrombophilias, both inherited or acquired. The most common acquired thrombophilia is the Antiphospholipid Syndrome. The thrombophilia is a state in which there are an hypercoagulability. It provokes clots that can impact in the placenta, and it interferes the blood to the fetus. So it can be the cause of the miscarriage. And there are congenital thrombophilia, that we can study with simple tests. And the most frequent are the mutation of the factor V of Leiden and the prothrombin mutation. And they are very easily detected by a simple blood test. And continuing with immunological causes, we have the alloimmune causes. These causes are a little more complicated because the miscarriages occurs because the body doesn't recognize the fetus as a part of its structure. I mean, the body produces antibodies to reject the embryos. They are the cells that are involved in it are the natural killer cells. They are a kind of lymphocytes with the capacity to destroy organisms that are not recognized as part of the body of the mother. This immunological rejection doesn't occur in all the pregnancies because in the pregnancy there is an immunological tolerance mechanism that prevents the rejections of the embryo. When this mechanism, this immunosuppression fails, then is when the pregnancy loss occurs. Okay. More causes of miscarriage can be anatomical causes. These are referred to malformations in the uterus. For example, the septum in the uterus is the most frequent, or when we have two small cavities, or alterations in the cavity of the uterus because of fibroids or polyps. For the miscarriage, is more frequent, perhaps a fibroid than a polyp, but we have to study if there are any. And for the last cause, we can talk about endocrine causes.
Okay.
Recurrent miscarriages can be due to hormonal problems in women, although this is the least common factors. But we can identify 3 situations. For example, the corpus luteum deficiency or insufficiency, when the ovary is not able to produce enough progesterone to maintain the pregnancy. But it's very difficult that it produces recurrent miscarriages. And another alteration is the diabetes mellitus, when the woman has the glucose in blood with high levels and it's not well controlled, and thyroid disorders, hypothyroidism and hyperthyroidism. Obviously, not all women suffering these illnesses will suffer miscarriages, but if they are not well controlled, perhaps it can be the cause of the miscarriages.
Well, so many things can cause it, and in so many times patients are feeling like it's their blame. So I think one of big messages of these Q&A is to say it's not their fault.
Yes, I always told the patients that because the question they made themselves is, what have I done to provoke the miscarriage? And I told her, you haven't done anything. It's not your fault. Yeah. We have to study if something is happening, but you haven't done anything to provoke this.
And Dr. Sanchez, how different is the miscarriage from an implantation failure? I mean, for patients, the pain is very similar because they start thinking straight away that they're going to have a baby. But what would be the difference?
Well, the difference is a miscarriage, there is already a pregnancy. There's an embryo growing and developing inside. And an implantation failure is when we transfer one embryo and it doesn't develop well and it stops and we don't get a pregnancy. The causes are very similar. If we talk about the causes of implantation failure, I will tell you more or less the same as I have already said. But we can define the implantation failure as a failure to achieve a pregnancy after transferring more than 3 good quality embryos in a minimum of 3 fresh or frozen cycles in women under 40 years old. It's very important to say that to be diagnosed of implantation failure, the age of the woman must be under 40 years old, because over this year, the cause of the implantation failure is genetic.
It's mostly genetic, yes. And you've been hinting that there are some tests that need to be done. What tests could patients do to try and understand what caused it so that they can maybe prevent it next time?
Oh, the test that we can do to prevent the implantation failure, you mean?
Yes, or the recurrent miscarriage.
Okay, well, if we remember what I have already said, if we think, well, first of all, I would like to say that despite the definition of implantation failure, many centers like us begin the study of implantation failure before. We don't wait to 3 good embryo transfer. After 2 good quality simple embryo transfer, we suggest to begin with the study of implantation failure, because if there is really some problem, it's important to solve the problem as quickly.
Exactly.
Okay? And what tests? Well, if we remember the causes of miscarriage that are similar to the implantation failure, it's very, very important to make for the uterine causes, for the anatomical causes, that is from the maternal causes, to do an ultrasound, a scan, in order to know if there is any malformation. If we have a 3D ultrasound, it's better because we can define the morphology of the uterus and diagnose the malformation better. And we can detect fibroids or polyps inside the cavity that the fibroid deform or is impacting in the endometrium. It affects to the implantation rate. Talking about the implantation, it's very important in the uterus, the endometrium, the receptivity of the endometrium. So how can we study the receptivity of the endometrium? Well, we can study with a test called ERA test, the window implantation. That is the time in which the receptivity is better in the endometrium. And with this test, we can know if the endometrium is, this implantation window is advanced or delayed. Okay, if the endometrium is pre-receptive or post-receptive. Okay, another test we can do is cultures of the vagina and the endometrium, because if there are endometritis, an infection and a inflammatory state of the endometrium, the implantation rate decreases, and it's important to know if there is some problem. With a simple culture, we can test if there's an infection, and with a biopsy of the endometrium, we can discard the chronic endometritis, and we have simple treatments to solve these problems. We also can do a study of the microbiota, because there are the endometrium and the vagina, they are not sterile cavities, and they must be colonized,
Yeah.
colonized with, they should be colonized in 90% by lactobacilli or other microorganisms. Another test to discard immunological and autoimmune factors, as I told before, the thrombophilias, it is just with a simple blood test, we can determine if they have any mutations to discard congenital thrombophilia, or to study antibodies to discard autoimmune thrombophilia acquired, such as Antiphospholipid syndrome. And we can study also the natural killer cells that are responsible for the rejection of the embryo. And if they are altered, they can be the cause of the implantation failure. It's very important, and for us it's mandatory when the woman is diagnosed of implantation failure to do an hysteroscopy. It's very important to have a direct visualization of the cavity in order to see if there is some inflammation, or if we can't see the size of the cavity. And with this technique, we can also do the treatment, because we can remove polyps or fibroids inside the cavity. We can remove septums, or we can widen the cavity in a very frequent malformation that we see in case of implantation failure, such as the T-shaped uterus. In this case, we can widen the cavity with the hysteroscopy. So we are doing diagnosis and treatment.
And I imagine with all the possible causes and the tests that we do, the treatment will be targeted at the cause that we find, if it's a cause that can be addressed or not.
Of course. It's very important to individualize the treatment. And in cases of implantation failure, these tests that I'm talking about are fundamental, but we have to do a study of each specific case and each specific couples, and suggest the test specific for each couples.
And then the treatment, I imagine, what sort of treatments in general are more common when people are presenting with repeated implantation failure or repeated miscarriage?
Well, when we have repeated miscarriage or implantation failure, as I have told before, the most important or the most frequent cause is the genetic one. So the embryo factor, we suggest to do a PGTA. PGTA is a pre-gestational genetic test of aneuploidies. It consists on doing a biopsy in the embryo after 5 days of development in the blastocyst stage, in order to study the chromosomes. It's like doing a karyotype to the embryo, in order to select only those embryos with the chromosomally normal. We call it euploid embryos. It's also important to make a karyotype to both partners, to the mother, the woman and the partner, in order to know if they are carrying some alteration that they don't notice. It causes no illness in them, but they generate embryos with alterations in the chromosomes. We can also study the gametes, only the sperm. We cannot study the oocyte, but we can study the sperm, the semen, by a technique that we call FISH, a FISH of sperm. We study the rate of aneuploids in the sperm. If it is over a percentage that we consider normal, that means that with this semen, there will be a higher rate of aneuploid embryos. So in these cases, if we know it in advance, we can suggest to do the PGTA to the embryos in order to select the better embryos and avoid miscarriages and implantation failures. The treatments, for example, for the thrombophilias are very easy, and we usually add either aspirin and or heparin. It depending on what we find, it will be high doses or low doses, prophylactic or treatment. It will depend on the what we find, the findings. And talking about the immunological causes, this is more complicated because we are still learning about it. There are no really, most of the treatments are empirically. There are a lot of studies, but not with enough evidence, scientific evidence. And in our experience, when we find alterations in the immunology, when we find alterations in the natural killers, we use corticoids in order to decrease the immune system to avoid the rejection of the embryos. We also suggest to add a perfusion of intralipids solution that what we do with this is regulate the natural killers in order to in order to decrease their activity, not to destroy the embryo as an strange organism. And well, we find it, I haven't told you, when we find an endometritis, an infection, obviously we give long protocols of antibiotic, and it's very important to give probiotics to increase the lactobacilli in the environment of the uterus and vagina. And I think
that's it.
Perhaps I'm forgetting something. Well, it's very important also in cycles of frozen embryos, the endometrium lining, that it's a sign of the receptivity. So there are some women that it is very difficult to get a good lining of the endometrium, and for improving this, we use high doses of estrogens orally, vaginally, or transdermal. We can add testosterone, sildenafil, vitamin A, and we have a lot of treatments to do in order to improve the lining and the receptivity. We also suggest to do a scratch in the previous cycle in order to improve this receptivity.
So I think the big message is that it's not women's fault when this happens, and there's so many things that could be contributing to the problem that they do need to be investigated. And some of the solutions are easier, some are a bit more challenging, but there is a way forward for them to get answers. Yes,
there is a way. And sometimes we don't find anything. That it's a bit frustrating, but although we don't find anything, many times we use empirically these medications. We usually use heparin, although there is no thrombophilia, because there is no thrombophilia, and nowadays with the thrombophilias we know, but perhaps in 10 years, we will know more thrombophilia than now, because 10 years ago we didn't know some thrombophilias than we know now. So our findings is that when we add these medications, we improve the results. So although we don't find anything, we add treatments that we feel they work empirically.
Dr. Sanchez, thank you so much for answering all our questions. I think it has been so useful to clarify our patients' questions, and I'm sure it will be really useful for our patients who are listening to today's Q&A.
Okay, I wish I helped someone. Okay.